Thank you, Dean Charney, and a warm welcome to our graduates, their families, and friends. Today's graduates represent diverse fields of inquiry spanning public health and healthcare leadership, biomedical and clinical research and informatics, biostatistics, and genetic counseling. Some of you will be continuing your graduate education, but most are heading to jobs in the healthcare sector where your work will have real-world influence immediately. You are an impressive group, and your influence has already been felt here at Mount Sinai and well beyond. Let me just give you a few examples of the impact of our graduates. One biomedical sciences master's student served as scientist in residence at the New York Academy of Sciences in downtown Manhattan and developed a year-long science research curriculum for a New York City middle school, which is now serving as a model of how we can dramatically improve the quality of science education in our public schools. Two of our Masters in Public Health students traveled to Uganda to work at local health clinics where they assessed malaria prevention programs. They evaluated the distribution of a special type of insecticide-treated net and formulated ways to optimize their use to achieve the World Health Organization's goal of universal coverage. We know that the use of these nets is associated with sharp decreases in the incidence of malaria, a leading cause of morbidity and mortality in Uganda and several other African nations. And another MPH student designed and implemented a research project on opioid relapse prevention and provided recommendations to the New York City Department of Health. The recommendations were presented to the Assistant Commissioner just last month and are now being used to drive a new public health campaign on opioid abuse prevention. Congratulations to all of you for the fine work you've undertaken here at Mount Sinai that is having real-world impact in New York and beyond. I'd like to say a few words about the latter topic, the opioid epidemic that we are currently facing today, because it cuts across the disciplines of all of today's graduates. It also is the topic of much of my own lab's research for over 3 decades. And it's impossible to overstate the severity of the epidemic. Here are some statistics. According to the National Institute on Drug Abuse, every day more than 115 Americans die from opioid overdoses. Deaths concentrated in communities and states that are suffering economically. This represents a 30-fold increase in opioid-related fatalities over the past decade. More people die from all drug overdoses today, and that's 64,000 individuals in 2017, than at the height of the AIDS epidemic from gun-related deaths or in automobile accidents. The economic burden of prescription opioid abuse alone is estimated to cost the United States $80 billion a year, and all drug addiction, $500 billion every year. And this is personal. All of us have a family member, a friend, or colleague who has struggled with addiction. What caused the opioid epidemic? It's complicated. The synthesis of very high-potency opioid drugs by the pharmaceutical industry to treat pain led to their greater use, with a 4-fold increase in prescriptions since 2000. There is no question that doctors and dentists bear a part of the blame, as these drugs are overprescribed. Many people are given opioids for conditions that don't require them, like a minor broken bone or a dental extraction. And the drugs are overprescribed for chronic pain as well, where they are less effective. While only 10% of people prescribed an opioid for pain get into trouble with it, 10% of an enormous number is a lot of people. And 80% of people who are addicted to heroin started with a prescription opioid. But interestingly, roughly 3 times as many people got their first prescription opioid pill, not from a doctor, but from a friend or pusher. Together, these data tell a story of how a wave of super potent opioid drugs became too available as they made their way into our communities. This is similar to other drug addiction epidemics that the older folks in the audience and I have seen in our lifetimes. The crack cocaine epidemic in the 1980s and 90s, the methamphetamine epidemic so well depicted in Breaking Bad in the 2000s, and of course the sustained epidemic of alcoholism, which still takes a greater toll economically and socially than all these other drugs. So one might argue that addiction is a plague of humanity that we've seen throughout human history. Our society's response, at least to the illegal drugs, has been to address each crisis separately without addressing underlying causes, leading to what might be called a whack-a-mole approach. My prediction and my concern is that we will find ways to tamp down the current opioid epidemic only to witness another drug taking its place. We need instead a clearer understanding of why certain individuals are vulnerable to addiction and develop truly preventive measures and cures. When I started addiction research 30 years ago, I naively thought that we'd have definitive treatments within 5 or 10 years. But such comprehensive solutions have been sadly elusive. We know that addiction has strong cultural, social, and psychological factors, but at its core, it is also a biological phenomenon. The ability of only a small number of chemicals, perhaps a couple of dozen out of hundreds of billions of chemicals, to attack the reward centers in a vulnerable brain. What makes a brain vulnerable to a drug of abuse? Roughly 50% of the risk is genetic, which makes addiction more heritable than high blood cholesterol or many cancers. But that 50% genetic risk involves several hundred genes and interacts with life's experiences to determine whether a given individual actually gets addicted or not. It also means that in order to conquer addiction, we need far more than a magic pill. Although highly effective medications are desperately needed and will help a lot, we also need to help individuals with addiction rebuild their lives occupationally and socially. This makes addiction, in my mind, very similar to other common chronic illnesses like heart disease and diabetes, for example, for which an increasing array of medical treatments are available, but which still require psychosocial interventions, healthy diet, exercise, stress reduction for maximal benefit. The major difference between addictions and these other medical conditions is that access to care is severely limited for addictions. It is difficult to find an addiction treatment facility in New York City. That's embarrassing. Stigma remains an enormous problem. The goal of our nation's efforts should be to better understand the biology of addiction so that more effective medication treatments can be devised, while parallel efforts are made to maximize the accessibility and effectiveness of behavioral and rehabilitation treatment programs, which we know work for many individuals. And to keep trying, never to give up hope, as most individuals with an addictive disorder do recover eventually after repeated interventions, if we can keep them alive. This is the world in which all of you embark today to pursue your own careers. My advice is to get out there. Don't be afraid to tackle the hard issues, the seemingly intractable ones, and we know there are many of those in healthcare. Even adding incrementally to the knowledge and practice base is significant. Slow, steady progress ultimately reaps tremendous benefits to society. We need you to confront these difficult questions of our time, knowing that there are few simple solutions and that success will require your bold imagination and working across many disciplines to improve our nation's public health. I wish you all well on your new adventures, and remember that no matter where your careers take you, you will always be part of the Mount Sinai family. Thank you.